Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization dedicated to furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I am a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. Lecture 17, Interpretation Basics of Cone Beam CT. So when we looked at things like cone beam CT, there's a lot of practitioners out there that think that cone beam CT is the be-all and end-all, and that we should be taking cone beam CTs of every patient before we work on them, after we work on them from an implant perspective, on 5-year-olds to diagnose pathology. And there's a few things that I want to basically speak about in terms of my own personal biases. But before we get there, I'm going to talk about what they call the LCF, or the looks cool factor. You talk about cone beam CT or CT, let's let you watch TV shows with emergency rooms and hospitals, and everyone's always like, okay, we don't know what's causing the growth on this person's foot or their brain or something. Let's take a CT scan to rule out this thing or not. So the question becomes, yes, it does look cool as compared to just a standard clinical examination of your patient or taking a proper history and physical. However, it doesn't necessarily add a lot to your, say, information base or database. But before we start talking about CTs, let's talk about the evolution of dental imaging. So basically, traditionally, we've relied upon bite wings and periapicals to help us. And let's go back to, let's not talk about implants, but just basic cariology. And the main problem was that most of us, not being Superman, we did not have X-ray vision, and we could not tell from a clinical perspective whether someone had interproximal decay. And as such, we really relied upon bite wing radiographs to sort of help us diagnose interproximal decay. And the same thing with periapicals in terms of determining if there's any periapical pathology with respect to a tooth or other issues that may be occurring with respect to unerupted teeth or impacted teeth and that sort of thing. What we have realized from the first day that we started in oral radiology was that basically a radiograph is a two-dimensional image, and that basically you can do things like the buckle, the buckle sliding move, in terms of the same lingual opposite buckle, in terms of moving a radiograph and taking X-rays in 2 dimensions to determine which object is in relation to the other object, either on one side or the other. However, you do have limited references to other anatomical structures for which something like this technique does not necessarily work. So in terms of evolution of dental imaging, once again, we had the panaural radiograph, which was introduced, and once again, it gave us a breadth of information. However, this was also only a 2-dimensional image, and it allowed visualization of mesial distal, but not buccal lingual relationships. There was also a magnification factor that became a bit of an issue, and this was anywhere from 20 to 30%, depending upon the system which you have. And Panoraxes would show anatomical structures. However, with the magnification factor, there would be some distortion of the image simply just by taking a circle plane and sort of flattening it. So we did get the CT scan. So this is the standard CT scan, not the cone beam CT scan, which was 3D imaging, and this would provide us with some sort of medical grade radiology capability. However, the costs of a traditional CT scan, of holding or having a CT scanner in your office was just unfeasible. So usually this requires sending the patient to some sort of radiology center or hospital-based spiral CT scan facility. Cone beam CT did come onto the market as basically a tool that could be available in a dental office or scanning center, and it would provide us with more capability. So what are these capabilities? So basically, the capabilities you get are from the diagnostic perspective in terms of pre-treatment planning, and one needs to consider do they require a cone beam CT in this particular case? There also would be basically no guessing upon position for the implant if stents are used in terms of either direction or depth. And I may add here that when you say there's no guessing on position, remember that the ultimate gauge of placing an implant inside a patient is actually working on a patient. Even with stents, there are error factors that are introduced, and the absence of experience or skill on the part of the clinician will not be made up simply by having a cone beam CT and some sort of lab-generated stent. So cone beam CT scanners or stents and stuff can be used in critical anatomical situations and for placing the implant in an ideal position in bone because it eliminates possible, and the key word here is possible, manual placement errors and matches planning to prosthetic requirements. And this was a study which was proposed back in 2000. So going a little bit more recently, 2006, when we started talking about flapless procedures, one of the things that cone beam CT did offer was minimally invasive procedures which may be requested by patients to reduce their anxiety and the pain experienced, the morbidity associated with implant surgery, and thus increased treatment acceptance rate. So with the flapless procedure, patients experienced pain in terms of less intensity and for shorter periods of time. There's also the issue of with flapless, you're reducing the amount of lack of blood supply to the periosteum, and as such, you're no longer compromising the blood supply to bone. So in 2003, image-guided systems provided a reliable preoperative assessment of implant size and anatomical complications, and it could be also used in flapless surgery. So communication could be improved between the implant surgeon and the restorative dentist, assuming that they are not the same person. And also the newest CT planning software provides as much information as possible to assist during surgical planning. So we can basically now visualize vital anatomical structures in 2D and 3D prior to surgery and assess the location of implants virtually prior to any surgical intervention. So you also have the ability to diagnose any anatomical situation specific to the patient, and this can be easily done, as well as plan for the type of implant, the position and orientation of the bone, and the process is fairly user-friendly and intuitive. So for those of you who may not necessarily stock a lot of implants inside your office and you're like, I don't know if I'm going to place a 10 millimeter, 11, or a 13. I'm not quite sure if I'm going to use a 3.7 platform or 4.2 or 4.5. With the CT scanner, you can pretty much know fairly accurately exactly which implant size you want to place if you don't, so that you don't have to sit there and order 6 implants, place one, and have to return the other 5. So before we start talking about cone beam CTs, we need to know what a regular CT scan is. And this is helpfully provided to us by a website called conebeam.com. So CT basic imaging, also referred as computed axial tomography or the CAT scan, involves the use of rotating X-ray equipment combined with a digital computer to obtain images of the body. So using CT imaging, cross-sectional images of the body organs and tissues can be produced. CT imaging has the unique ability to offer clear images of different types of tissue. CT imaging can provide views of soft tissue, bone, muscle, and blood vessels without sacrificing clarity. Other imaging techniques are much more limited in the types of images that they can provide. These are all true. And going back to the last point, what you need to realize is that you can provide views of soft tissue, bone, muscle, blood vessels without sacrificing clarity. But remember, when you want more clarity, it means a higher radiation dose for the patient. So to understand the difference between CT imaging and other techniques, consider an X-ray of the head using basic X-ray techniques. The bone structures of the skull can be viewed. With MRI, blood vessels and soft tissues can be viewed, but clear, detailed images of bony structures cannot be obtained. And the reason we point this out is that MRI has an ability to gain an image of the head and neck, however, without any radiation dose, because you're using magnetic, right, so magnets, as opposed to using X-rays. On the other hand, X-ray angiography can provide a look at blood vessels of the head, but not the soft tissue. CT imaging of the head can provide clear images not only of soft tissue, but also of bones and blood vessels. And this has to do a lot with sort of progressions that have been made in CT scanning software and CT scanning equipment. So CT imaging is commonly used for diagnostic purposes. In fact, it is a chief imaging method used in diagnosing a variety of cancers, including those affecting the lung, pancreas, and liver. Using CT imaging, not only can physicians confirm that tumors exist, but they can also pinpoint their locations accurately measure the size of tumors and determine whether or not they spread to neighboring tissues. In addition to the diagnosis of certain cancers, CT imaging is used for planning and administering radiation cancer treatments, as well for planning certain types of surgeries. It is useful for guiding biopsies and a range of other procedures categorized as minimally invasive. Thanks to its ability to provide clear images of bone, muscle, and blood vessels, CT imaging is a valuable tool for the diagnosis and treatment of musculoskeletal disorders and injuries. It is often used to measure bone mineral density and to detect injuries to internal organs, and CT imaging is even used in the diagnosis and treatment of certain vascular diseases that, undetected and untreated, have the potential to cause renal failure, stroke, or death. So what is a cone beam CT? In layman's terms, CBCT is a compact, faster, and safer version of the regular CT. So through the use of a cone-shaped X-ray beam, the size of the scanner, radiation dosage, and time needed for scanning are all dramatically reduced. A typical cone beam CT scanner can easily fit into any dental practice and is easily accessible by patients. The time needed for a full scan is typically under 1 minute, and the radiation dosage is up to 100 times less that of a regular CT scanner. So, dental panorexes and periapical radiographs can be used to evaluate the site for a dental implant placement. The problem with panorexes, as we discussed previously, is that they suffer from magnification distortion and require radio opaque markers for correction. And I may add one thing, that when they say radio opaque markers for correction, remember, a lot of the times that this magnification factor, you will know what it is for your particular machine. So for example, the machine that I use, the Gendex digital Panorex machine, we know that it's 30%. How do we know it's 30%? Because we place a 10 millimeter implant inside a patient, you go and measure it, and it's 13 millimeters. So you know that there's a 30% increase in the size. So you have a 30% magnification factor. PAs are very dimensionally accurate, but they're limited in being able to show vital anatomy, like the inferior alveolar nerve and sinus anatomy. So the CBCT gives an accurate three-dimensional image of the jaws and can also be used to measure bone density. The key thing here for CBCT, and this is something you need to realize, especially in young people like children, is that the radiation dose is a lot higher. So a dental panorex, you give about 26 microsieverts of radiation, and this is using the plain film dental panorexes, not the digital ones. With CBCT, you're talking about at least 90 microsieverts, and the lower doses are basically render less information. So there are CBCT scanners that say, okay, we don't give as much radiation. However, as many of you who've been out there and working in the world of digital imaging, you'll realize that some panorexes or some digital radiographic equipment, things you can buy in various places, they don't necessarily look as clear as, say, like, these nice panorexes that you see advertised at various conventions and stuff. So basically, unfortunately, in order to get more information, you have to give the patient a higher radiation dosage. So here's just a diagram or a chart basically depicting different types of cone beam CT scanners and the amount of radiation that was delivered as compared to a standard dental panorex and also to our standard periapical radiographs that we use for patients. So with that being said, there was a study in 2013 on patient radiation dose and protection from cone beam CT. And basically it stated that the patient radiation dose is much lower for cone beam CT than for helical CT. Well, we already knew that. And that the dose was closely related to the FOV and exposure parameters used for a CBCT examination. So without alteration of any other exposure parameters, the larger the FOV used for scanning, the higher the radiation dose. And this is kind of a given. So compared with conventional dental radiography, the effective dose of CBCT is several to 100 times higher. So to reduce the patient's dose to the greatest possible extent, the chosen CBCT scanner should be in accordance with the diagnostic task at hand. So if you need to scan, say, a quadrant, you scan the quadrant. You don't scan the whole head. As well, they advocate that a thyroid collar should be used for CBCT scanning and that wearing leg glasses is recommended when it does not detract from image quality. So in a typical CT scan, which is still used, you have to use an implant overlay to select the implant, and you still are basically offering the patient only 2D planning. So what CT planning software provides is as much information as possible to assist during surgical planning and an ability to visualize vital anatomy in 2 dimensions and 3 dimensions prior to surgery. And you can also convert CT scans, or the CBCT scans, the DICOM files, to 2D and 3D imaging. And you have the capacity to assess the location of the implant virtually prior to the surgery. So, I mean, if you can basically take a test home and write the test the night before the exam or test or whatever it is, and then basically the next day have to copy it, I mean, it's going to obviously give you a better result if you were subscribed to that analogy. So computer-assisted treatment planning basically enables rotation of the scan in 3D and placement of implants around anatomical concerns, and you can view in both 2D and 3D at the same time. So this diagram here, basically from the analysis view perspective for some of the software out there, gives you an opportunity to basically sort of like lay it all out. So you see there's a 3D rendering of the position present. There's some sort of screen layout change. You can define the jaw arch of interest, define your volume of interest. You can define your mandibular nerves. You can register X markers in places you don't want to go. You can place mock implants, and there's different types of measurement tools. And we'll see how some of these things come into if you're using, say, an off-site CT scan facility. Like in Canada, we have one called Cataraqui, which basically for a very reasonable sum of money will take a scan and also have an oral radiologist provide you with a report and basically all the information that you could possibly want. One other last thing about CT scans before we get to that is that there, in terms of pathology, it does offer us some greater imaging from a differential diagnosis perspective. So looking at what a CBCT can offer you, this is just a depiction of a patient who we were able to send off to the scan facility, and they were able to give us back this image, which gives us a fairly good idea. I mean, dentists, us being fairly intelligent individuals, green means go, red means no, and yellow means, perhaps, just like the stoplight. So in this case here, you can see that the CT scan software has been used to basically virtually place implants inside a patient, but the numbers are the FDI positions of the teeth, and outside of them you can see the 4x9 or the 5x8 is the proposed implant size. So in the areas where it's green, there's sufficient bone volume to support that size of an implant at that length without getting into trouble. And in areas where things are red, basically what it implies is that there's anatomical limitations with respect to what can be done, either as a result of a lack of bone or a lack of bone volume, or the requirements for other procedures. So in the maxilla, that would typically involve either some sort of bone grafting, on-layer appositional bone grafting, or sinus lift or something like that. And in the case of the mandible, the similar sorts of things, and possibly issues with respect to nerve lateralizations, or basically, not being able to place an implant as a result of some sort of nerve being involved in the surgical area. And you can also see that you get the traditional scans as well as the scan views. If you download these into your own software, you can basically go through these things in three-dimensional and basically check out these areas yourself, which is kind of cool. A lot of these scan facilities like Cataraqui actually provide you with some sort of software which you can download as well and use. And when I'm telling you that these things are available off-site, basically what I'm trying to tell you is that we do not have a cone beam CT scanner in our facility. Now some people go out and say that this is the standard of care, that every facility should have one. I think the only people that are saying it's the standard of care are the guys who are selling it. So if it's the case that you are not doing a lot of CT scans, or you don't have a lot of cases where CT scan is required, and the key word is that it's required, it basically, you have to consider whether it's going to be something which you need to add into your own office. And I mean, from the cost perspective, when you start breaking down the business side of the profession, a typical CT scanner, at least a good one, you're looking at least $100,000 plus the regulatory aspects of having it inside your office. Not to mention, you need to have a computer or an acquisition station. You need to have up-to-date software. You need to train your staff on how to use it, and whatnot. So I mean, if it's in Canada anyways, or at least in Toronto, there are CT scan facilities available where basically for like a reasonable sum of between $200 to $300, you can have an oral radiologist not only take the scan for you, but provide you with a very detailed report. And this is not a pitch for the facility. I'm just telling you that this is something which you need to consider. So looking at another view, so this would be the sagittal view of the right maxillary sinus. You can sort of see, you can also rule out any type of sinus pathology. One of the other neat tidbits for those of you who like doing sinus lifts is that you also have to realize that the middle superior alveolar artery sometimes runs in close proximity to those areas, especially in the anterior aspect of the maxillary sinus antrum, right, runs on that bony wall. So any of you who've sort of encountered that are like, okay, I kind of didn't want to hit that. That's kind of scary. So the nice thing about a CT scanner is you can actually depict whether that's going to be an issue for you in your surgery. You can also rule out sinus pathology, adhesions, and things like that. And here's another view here, basically indicating in this patient's particular case, moderate mucositis in the left maxillary sinus. And then finally, the last two views we have here, one is basically an axial view, coronal view, and sagittal view of a particular area where we're assessing that maxillary sinusitis for the patient. And then lastly, you get these little shots as well, which basically depict things into slices, and basically gives you a great opportunity to sort of, do your own sort of CT analysis in terms of determining what the ideal position for an implant would be. So the next lecture we have is lecture 18, which is all about marketing dental implants. And we're going to basically talk about some business aspects of marketing and also talk about the ways that implants should be marketed and perhaps implants should not be marketed to save you the headache of of miscommunication and a dissatisfied patient. So as per all of our lectures, we provided you with the references that have been used in the production of this entire lecture series. And on behalf of the entire dental treatment team at the Cataraqui Woods Dental Implant Institute, I want to thank you for listening to our lecture.